Hello and welcome to the Echo by Web YouTube channel. It is a channel for professionals, mainly cardiologists and sonographers, but not only, dedicated to the world of echocardiography. The aim of this channel is to provide the basic physiopathology and methodology which are necessary to understand how to perform and interpret a complete echocardiographic examination. This channel will deal with many of the topics we all have to engage with in daily practice: valvulopathies, cardiomyopathies, systolic and diastolic function, and also new technologies like left ventricular systolic strain analysis. My name is Paolo Barbier. I am broadcasting from Italy. I am a cardiologist with a special interest in echocardiography, and I will guide you through talks and clinical cases from my clinical experience, addressing a wide range of echocardiography topics. My imaging, the images that you will see, are based in Italy and in northeast China, where I have worked for about 5 years. Echo by Web is also a website, echobyweb.com, where you will find much of the materials I will present in this channel. In here, you can see the QR code to access the Echo by Web site, for example, for your cell phone right away. The topic of these series of talks, which span over 6 videos, is the echocardiographic analysis of left ventricular diastolic function and dysfunction as seen in the real world. It is a fast, synthetic, basic approach to this topic, which is quite large, and I will provide further on more detailed, a large video with a more in-depth approach. Now, these talks assume that you have a basic understanding on how to perform pulse Doppler and continuous wave Doppler interrogation of intracardiac flow, and also how to use tissue Doppler, myocardial tissue Doppler. And it is also assumed that you know how to perform basic echocardiographic measurements. However, you will find in the website echobyweb.com, I've just mentioned it, a large quantity of material, educational materials to address these topics. This is an outline of the 6 talks on the analysis, the echocardiographic analysis of left ventricular diastolic function and dysfunction. So the first talk we will look at definitions of diastolic function, diastology, and its clinical utility, the utility of the echocardiographic analysis. And then there will be a basic presentation of the physiopathology of left ventricular diastolic function. In the second video, we will look at how to estimate left ventricular filling pressures with echocardiography, and we will look at the current recommendations, the 2016 and 2025 latest recommendations on the analysis, the echocardiographic analysis of LV diastolic function. The third video, we will see a complementary analysis which is based on the assessment with echocardiography of pulmonary diastolic pressure, and then we will see how to estimate LV relaxation and compliance with echocardiography. The fourth video will all be about how to grade with echocardiography diastolic dysfunctions. The fifth video will be on how to report with echocardiography diastolic function and dysfunction, and we will see a series of clinical cases. In the sixth video, we will address the problem of sinus tachycardia and how to solve it, so to perform the analysis also with a fast heart rate. Then we will look on how and why to perform the Valsalva Maneuver. We will look at specific patient populations and see the conclusions. This is video number 4, the topic of which is the echocardiographic grading of left ventricular diastolic dysfunction. Now let's look at the grading of left ventricular diastolic dysfunction. How do we integrate our evaluation that we have just seen of left ventricular relaxation and compliance to determine the grades of diastolic dysfunction? This table is taken from the 2016 recommendations from the American and the European Society of Echocardiography. you have normal physiology, and then you have grade 1, 2, and 3 diastolic dysfunction, also known as grade 1 or impaired relaxation, grade 2 or pseudo-normal, and grade 3 or restrictive. You will find a more in-depth description of these grades in my website echobyweb.com that I have previously shown you how to get to. So left ventricular relaxation is primarily determined by tissue Doppler A', as we have seen, and left atrial pressure is determined by using the algorithm that we have just overviewed. And then we want to consider the mitral EA ratio, the average E on E' ratio, peak velocity of tricuspid regurgitation, and the biplane left atrial volume index. So according to this table, the main differentiation and faster differentiation between grade 1 impaired relaxation and grade 2 pseudonormal is the EA ratio, less or more than 0.8. The other indices, E on E' and regurgitation of tricuspid regurgitation velocity, mainly relate to left atrial pressure. Left atrial volume index is useful, but it's not very precise in pinpointing the grades of dysfunction. It mainly supports the presence of a dysfunction. So let's proceed with the grading of diastolic dysfunction. I prefer to use a more descriptive approach. I will show you in a minute, but let's look at the grades in a little more detail on this slide. So here we have on the left the parameters that we use, so relaxation, chamber compliance, filling pressures, and the prognosis. We have seen how to evaluate with echocardiography these parameters in the previous slides. Here on the left we have normal function, and normal diastolic function is characterized by normal relaxation and normal chamber compliance. In this situation, the filling pressures are normal and the prognosis of the patient is positive. Compared to the normal physiology, grade 1 or impaired relaxation is characterized by an isolated, prolonged left ventricular relaxation. This relaxation must be described in the report and can be mildly or severely increased, and we should describe this, the quantity of impaired relaxation. Chamber compliance is normal and filling pressures generally are normal. Grade 2 and grade 3 are characterized by a progressively impairment of chamber compliance, which is superimposed on at least moderately prolonged relaxation here. And at the same time, we have a progressive increase in filling pressures, which are increased in grade 2 and a severe increase from grade 3 to grade 4. At this point, the prognosis turns to negative the moment that the filling pressures increase. So generally speaking, at pseudonormal on to grade 3 and starting from pseudonormal to grade 3 and grade 4. Please note that in the real world, you may find patients with severely prolonged relaxation, so they are still in grade 1 impaired relaxation but severely prolonged relaxation, and in these patients you may find an initial increase in filling pressures, and this is not clearly stated in the recommendations. But what does grade 4 restrictive filling, fixed restrictive filling mean exactly? And we'll see this in the next slide. So the grades of left ventricular diastolic dysfunction have been introduced in the late 90s. This is a review paper, 2004, published in the Journal of American Society of Echocardiography. This is a review paper where you can see the relationship between the stages or the classes of diastolic dysfunction 1, 2, 3, and 4, and their relationship with mitral inflow, pulmonary venous flow, and tissue Doppler. Pulmonary venous flow at that time was a first-line assessment. Now it's become a second-line assessment. There are a few differences because the cutoffs are a little bit different. E on A, the cutoff here was 0.75 between stage 1 and 2. And you can also see that the label of E prime was different. It was called E on A. So what does restrictive mean? It means that compared to stage 3 or reversible restrictor, you see what it says reversible, because what happened here is that if you gave diuretics to a patient in stage 3, a reversible restrictor, reversible meant that by giving diuretics and reducing preload, so changing and reducing preload, you could see that the pattern of E on A reversed and went back to an impaired relaxation pattern with a marked decrease of the E wave, increase in the deceleration, and an increase in the A wave. So from EA of 1.5, you went back to an EA of 0.75. What do I mean by going back? Because with the natural progression of the cardiopathy, any kind of cardiopathy, usually you had a progression from stage 1 to stage 3, and by an increase in the A wave, a reduction in the A wave, and you went from this impaired relaxation pattern to the reversible restrictive. And you could go the way back by reducing preload. This could not happen in patients with fixed restrictive. So a patient was labeled as stage 4 if given diuretics and reducing preload, the E on A mitral pattern did not change. Now let's see a clinical example to clarify this concept of the dependency of mitral and pulmonary venous flow on load. The clinical setting here is the early postoperative period of coronary artery bypass surgery in a 53-year-old patient. The patient is being monitored with intraoperative transesophageal echocardiography, and this is why you see a negative transmitral flow, because we have the transducer in the esophagus facing posteriorly the mitral valve. And typically you also see a positive pulmonary venous flow here below. So, on the first panel on the left labeled A, we see the baseline, and we see a typically impaired transmitral flow pattern with a small A wave and a larger tall A wave. And pulmonary venous flow shows a large systolic wave and a small diastolic wave. And all this physiology of impaired relaxation with normal left atrial compliance, a big systolic wave, matches a pulmonary venous wedge pressure, a normal pressure of 7 millimeters of mercury. Well, suddenly the cardiologist observes an extensive anterior wall hypokinesis, and concomitantly the wedge pressure shoots up to 30 millimeters of mercury. So we are observing acute ischemia with increased filling pressures. What about the diastolic determinants? Well, what we see here, the first thing that we should note is an immediate reduction of diastolic time, of the filling period, or the transmitral flow time. And we have also a tall peaking E wave with a marked reduction of deceleration time. And we don't see an A wave. So what do you think the A wave is? Well, here the EKG that we have on the screen is very useful because it tells us what happens to the A wave. As you can see, the P wave here, so the A wave must follow the electrical P wave. So the A wave should be here, and you see that it's practically disappeared. Could be this, but this could also be an artifact. So we only have an E wave. The A wave is completely gone because of the marked increased left atrial afterload. And the increased afterload is left ventricular diastolic pressure, which must have been very high at this point. On the pulmonary venous flow, we have a marked reduction of the systolic wave and an increase of the diastolic wave symmetrical to the increase in the mitral E wave. So this is a grade 3 restrictive pattern with a marked sudden increase decrease in left ventricular compliance, and with an underlying marked impairment of left ventricular relaxation. At this point, the anesthesiologist infuses ambrinolone in the patient, which is an arterial vasodilator, which increases also venous capacitance, reduces oxygen consumption, has positive effects on both LV relaxation and compliance. And in the C panel here in the middle, we see the immediate effects on diastole with an increase in filling time. The E wave is the same, but deceleration time increases significantly, and the A wave is back. You see the P wave here, and the electrical component of the A, and the atrial contraction, and the A wave. So this means that left ventricular compliance is increasing. And on the other hand, the pulmonary venous flow pattern doesn't change much. At this point, wedge pressure is still highly increased. So what we deduct here is that probably the atrial situation hasn't changed, but left ventricular compliance is getting better. Following, we see in panel D that we have an increase in pulmonary venous flow systolic wave and a decrease in the diastolic wave, which reflects an increase in left atrial compliance and a decrease in the wedge pressure, which at this point is 17 millimeters of mercury, so a significant increase from 30 millimeters of mercury. The A wave is also somewhat increased here on the transmitral flow profile. And then in panel E, at this point, we have reversion to the baseline with an impaired relaxation, transmitral and pulmonary venous flow patterns, and normalization of the filling pressure, of the wedge pressure, and concomitantly the baseline, the wall motion of the left ventricle is now normal. This is a graph that exemplifies the situation, the clinical situation we have just discussed and seen. And this graph stresses the fact that the mitral up here and pulmonary venous flow profile down here are determined by both the determinants of diastole, relaxation and compliance, left ventricular relaxation and left ventricular compliance, but also by the loading conditions. So preload, left atrial pressure, and also aortic arterial pressure, which is left ventricular afterload. And we also have seen that left ventricular and diastolic pressure is in fact also the afterload of the left atrial systolic function, the A wave. Thus, left ventricular ischemia in our example prolonged LV relaxation, reduced left ventricular compliance, and increased left ventricular preload, such that the transmitral flow profile transitioned from grade 1 through grade 2 up to grade 3, whereas the beneficial effects of unloading by medical therapy transition back the mitral pattern from grade 3 back to grade 1. There is a remodeling, let's say, of the transmitral flow pattern, but also of the venous flow pattern. A restrictive pattern, transmitral pattern, as we see by this arrow with a single direction, cannot transition back by unloading the ventricle. We have also seen another interesting fact where in this clinical example, so in the setting of acute ischemia after bypass surgery, and we saw that the transmitral flow seemed to reflect more left ventricular compliance, whereas pulmonary venous flow was correlated more with left atrial pressure and left atrial compliance. So this would be the effect of ischemia here from left to right, a progression from low to high filling pressures, from prolonged relaxation, mildly prolonged relaxation to severely prolonged relaxation, from normal compliance to decreased compliance. And the effect of therapy, which goes the other way, reduction of loading and an increase in left ventricular compliance, whereas relaxation goes from severely impaired back to mildly impaired. I would also like to stress the fact that this setting that we are seeing is valid not only for acute changes in load, like we have seen in this post-coronary bypass ischemia, acute ischemia, but it's the same thing happens also chronically, because with the progression of hypertrophy or of LV ventricular fibrosis, we transition from grade 1 impaired relaxation to grade 3 impaired relaxation plus reduced compliance with increasing pressure and negative prognosis. And we can transition back. So if you treat hypertension and you reduce the volumes, you reduce hypertrophy, you can transition back from high filling pressures and a grade 3 back to a grade 1. And this was the example of hypertension, but the same example could be made also for example, chronic dilated cardiomyopathy, ischemic cardiomyopathy, or primary cardiomyopathy. So we have a large graph here, quite complicated. We will spend a few minutes here. And this is to show you how to do with echocardiography the grading of diastolic dysfunction, how it looks like in the real world analysis. So I have placed top to bottom here the flow profiles of pulmonary regurgitation, transmatter flow, pulmonary venous flow, and tissue Doppler of the metalanus. You will immediately notice here, up here are the gradings of the diastolic dysfunction grades. There are two gradings. These ones below are the 2016 recommendations. So you have class 0 here with normal filling pressures. And here you have class 1 with normal filling pressures, less than 12. Wedge pressure. Here you have again class 1 with less than 12 filling pressures, class 2 pseudonormal, and class 3 restrictive. You will immediately notice that this grading up here that I propose you, in this grading there are 2 0 grades, normal grades, one for patients be less than 50 years old and one for patients over 60 years old. And there are also 2 classes of class 1, 1A and 1B. Now I propose this to take into account the real world of all the patients which have impaired relaxation but should be considered physiological impaired relaxation, and then the fact that we have a class of patients, I call them 1B, which have an impaired relaxation pattern but beginning to have high filling pressures. These intermediate situations here are not, I think, not sufficiently taken into account by the current recommendations. And down below here, you will find all the other diastolic parameters that we use for diastolic dysfunction evaluation and grading. So you have the left atrium volume index, for example, here 32 milliliters per square meter. The ejection fraction here is 57. The pulmonary diastolic pressure as measured with echocardiography. Here 4 plus 6 means 4 is the end diastolic gradient of the pulmonary regurgitation, and 6 is the grading of right atrial pressure through the inspiratory collapsibility of the inferior vena cava. And then we have tricuspid regurgitation peak velocity, 2.1 meters per second. Then here we have the mitral E on A ratio, 1.7, and deceleration time of the E wave, 155 milliseconds. Then we have pulmonary vein systolic diastolic ratio, so less than 1, more than 1.5. Mitral E prime, this 17 here, and the E on E prime ratio, which would be the 5 here. And then the difference between the reverse pulmonary venous flow A wave here, the duration of the reverse A wave, and the antegrade A wave. So, which would be less than 0 here in normal and becomes more than 30 here in this grade 3. So, in this, for example, normal, young, less than 50-year-old subject, we have a normal left atrial volume index, 32, normal ejection fraction, normal pulmonary diastolic pressure, normal 2.1, peak velocity tricuspid regurgitation, normal Eon A ratio, normal deceleration time, and normal E prime, well, high E prime, it's actually 17, normal Eon E prime, and no significant difference in the A wave durations. Now, in normal young subjects, the mitral valve flow here is similar to the grade 2 mitral valve flow. That's why grade 2 is called pseudonormal. They're quite similar. The E wave, the peak E wave, the peak A wave, the Eon A ratio here, 1.7, 1.3, and this deceleration time also, 155 milliseconds, 178 milliseconds. So they are quite similar. However, in normal subjects, the E wave deceleration time correlates closely with relaxation. So the shorter, the fastest the relaxation, the shorter the deceleration time. So the shorter, the healthier the relaxation. Whereas in grade 2, deceleration time, which has a similar value as in a young normal subject, the deceleration time here correlates with left ventricular compliance. The shorter the deceleration time, the lower the left ventricular compliance, because at this point in early diastole, the pressure of the left ventricle, the filling pressure, increases rapidly. And you can also see that the main difference here is made by the mitral E prime, which, as we said, is the baseline measure, is the best measure of left ventricular relaxation, which is normal in the young subject, 17, and is markedly reduced in the class 2 UC4. So this is where you make the difference with the mitral E prime, and also the Eon E prime, which reflects left atrial pressure, which is 5. It's normal in the young subject, normal subject, and it's 29 in grade 2. So pseudonormal pattern, but with clearly prolonged relaxation and high filling pressures. Same as for the mitral valve flow, the pulmonary venous flow. In both the normal young patient and in the grade 2 pseudonormal, you see a diastolic pulmonary venous flow which is higher than the systolic, here and here. Very similar, pseudonormal. But here, the diastolic wave correlates with a faster relaxation, whereas here, the high diastolic wave correlates with a lower compliance and a faster increase in left ventricular pressure during the first third of diastole. We must remember that the mitral E wave and the pulmonary venous flow diastolic wave share the same determinants, kind of symmetrical, and this helps you in the diagnosis. In older normal subject, the second column here, so grade 0 but above 60 years, the E wave deceleration time is longer. You can see it 119 versus 155. It's longer, significantly longer, but still within normal limits. And what happened here is that relaxation is physiologically prolonged in older subject. So relative relaxation is reduced. The velocity of relaxation is physiologically reduced with age. And you can see here that the E prime is from 17 goes down to 12, so it's still normal, but lower normal values. And what happens is that because relaxation is reduced, we have an increase also of the late filling to compensate for somewhat reduced early diastolic filling in these older subjects. But left ventricular compliance is normal in these older subjects because E wave deceleration time is not reduced, the EA ratio is not increased, the A wave is still large, and there is also a large pulmonary systolic wave. So at this point, left atrial volume also is still normal, and E on E prime is normal. So prolonged relaxation, but compliance of the ventricle, compliance of the atrium, and filling pressures are normal. Let's look now at the patients with a prolonged relaxation physiology, though grade 1, as stated by the 2016 recommendations, and I label this as a 1A, which is the classical grade 1 prolonged relaxation. This is a patient with an aortic valve prosthesis. We have a normal ejection fraction of 61. We have at this point an increase in left atrial volume. Left ventricular relaxation here is prolonged, and you can see that the E wave is down. A small E wave, a prolonged, an increase in deceleration time. In this case is quite prolonged, 420 milliseconds, and we have a higher A wave, and the EA ratio is at 0.6. Left ventricular compliance in this patient is normal because of the low EA ratio and the long deceleration time, and the S wave of pulmonary venous flow is high, which stands both for left atrial normal compliance and also the left ventricular compliance. Filling pressures are normal. You can see this from the end diastolic velocity of pulmonary diastolic regurgitation. It's 5 millimeters of end diastolic gradient plus 6 of a normal inferior vena cava collapsibility, which gives you an estimated wedge of 11. Low filling pressures, which is also confirmed by a E on E prime of 6, which is normal. So prolonged relaxation, normal compliance, normal filling pressures. Let's move to diastolic dysfunction grade 1, but grade 1B. So why this grade 1B? Because in some patients with a impaired relaxation physiology, left ventricular pressures, left ventricular filling pressures are found to be initially increased, as in this patient with an ischemic dilated cardiomyopathy, severe reduction of left ventricular ejection fraction, and mildly dilation of the left atrium. In this patient, we diagnose a severe prolongation of left ventricular relaxation. Why this? We have a very low E wave, so low that we cannot measure the prolonged E deceleration time. And you can see here the mitral E prime is 1.5, so it's severely decreased. Here you can see the E prime, which is severely reduced. Now it's very difficult here to evaluate the compliance of the left ventricle, but anyhow, it seems that because of the high prevalence of this extreme increase of deceleration time and reduction of relaxation. But you can see the diastolic pulmonary venous flow here wave, which is increased, which could point at an initial reduction of left ventricular compliance. And finally, the crucial point in this 1B grade is that you have an initial increase in filling pressures. And in fact, you can see that the end diastolic gradient of pulmonary regurgitation here is 9. So it's increased. And if you add this, the normal right atrial pressure 6, as estimated by the collapsibility of the inferior vena cava, we have an increased estimated wedge pressure of 15 millimeters of mercury. Whereas the E on E prime here is of no help because it's in the grade zone. And then we move on to grade 2, pseudonormal class dysfunction. In a patient with a normal ejection fraction, severe dilatation of left atrium and mitral regurgitation. In this patient, we have severe prolongation of left ventricular relaxation here. You can see the E prime of 4. However, LV compliance is also reduced because we have an increased E wave, notwithstanding the decreased E prime, and the EA ratio is 1.3. We have seen this before when we were discussing the difference between pseudonormal and young normal. And filling pressures, well, they are high. The end diastolic gradient of pulmonary regurgitation is 12, So by itself, it states the wedge pressure is probably increased. At this, you have to add 6 of a normal right atrial pressure. So we have 18 millimeters of mercury of an estimated, non-invasively estimated wedge pressure. And then we have also the E on E prime here, 29, which confirms increased left ventricular filling pressure. And finally, we have the patient with grade 3 restrictive filling pattern. And in fact, we have a typically restrictive mitral and pulmonary venous flow filling pattern, and increased E wave, decreased deceleration time, decreased A wave. The E on A ratio is high, it's 2, and we have a prevalent diastolic dominant pulmonary venous flow, and we have a reduced E prime, so prolonged relaxation. So prolonged relaxation, reduced compliance of the left ventricle, as we have said, because of the high peaking E wave, E on A ratio, and reduced deceleration time. And then we have increased filling pressures because the increase and diastolic gradient of pulmonary regurgitation of 12. And we also have a severely here a moderate dilatation of the left atrium and a severely reduction of left ventricular ejection fraction. This is an ischemic dilated cardiomyopathy. This is the end of video number 4. Please proceed to video number 5, from reporting, echocardiographic reporting of diastolic dysfunction to clinical cases.